All right, you're live.
All right. Good afternoon, everybody. Welcome to our Johns Hopkins Wiki Virtual Toolkit series, which is put on by our Ryan White HIV/AIDS Part D program. My name is Allison Agu. I'm a professor of adult and pediatric infectious diseases and the program director here. I also here assisting is Marina Terraforte, who's a program manager. Next slide, Marinas. So hopefully this is not your first time to our virtual toolkit series. Is for in terms of by way, go back one slide, Marina, it's getting all excited. Briefly about our GH Wiki Partnership for Excellence. We represent 6 distinguished programs across Maryland, and the goal is to provide comprehensive, quality, family-centered care for women, infants, children, and youth, therefore the Wiki. I represent the Pediatric Adolescent HIV/AIDS program. We also have the Women's Program, the Sinai Hospital Support Services, University of Maryland HIV program, and both the Emerge Gender and Sexuality Clinic here at Hopkins and the HIV Psychiatric Service. The vision is really to create a more coordinated response to HIV care by really leaning into our mutually beneficial relationships to enhance the quality of care we provide as a community. The mission is to build upon our existing structures, but also to network amongst each other to make sure that we are providing the best multidisciplinary care. The goal of this series is to engage and amplify experts. Really excited in our 2 years of doing this. We've reached multiple continents, thousands of people. Please, if you haven't already checked out our YouTube page, please do that. And thank you, HRSA, for the grant that funds us. Next slide. And I always say, in terms of engaging and amplifying, we recognize there are experts all around us. And so see something, say something, do something. If you have something that you'd like to share, we'd love to provide a platform for you to do that. Today, I am so excited to have Dr. Matthew Hamill, who's assistant professor of infectious diseases at Johns Hopkins in Baltimore. He is interested in all things sexually transmitted infections and HIV, prevention, treatment, retention, and care. His research focuses on rapid point-of-care diagnostics for STIs in low-income settings, and he provides patient-focused treatment for those with or at risk for STIs and HIV, including pre-exposure prophylaxis and PrEP. He has expertise in providing care for LGBTQ+ communities. He's UK trained, so you hear his fabulous accent when he started. He received his medical degree in 1998, trained in internal medicine, followed by STIs and HIV training in London, UK, and then spent 3 years conducting research in Soweto in South Africa. In addition to his primary affiliation with Johns Hopkins, he's also affiliated with the Department of Population, Family, and Reproductive Health at the Bloomberg School of Public Health. Matthew, please take it away.
Thank you so much for that really generous and warm introduction. I just want to make sure that I'm sharing my slides correctly. How does that look?
Fantastic.
Okay, great. So thank you again, Alison. I really appreciate the opportunity to be here and spend some time with this group to share some of my thoughts and expertise around sexually transmitted infections, and I hope try and make it interesting for you all and provide space for questions, discussion, etc. So here are my disclosures, which I will just leave up for a moment. And I'd really like to draw your attention to the note in purple at the bottom of the slide. I'll just leave it for a moment so that everyone can read. I think that the language that I use and that we use when we address one another is so important. So the objectives of this study are, you can tell what I've been doing all day. The objectives of this talk, rather, are listed here, and they were on the previous slide as well. So I won't belabor them, but we'll hopefully get through all of these so that by the end of this session, you will feel comfortable in being able to sort of discuss the things listed on this slide here. So just to start with some background and context. If we look globally at the burden of curable STIs, and so by that I mean chlamydia, gonorrhea, syphilis predominantly, but if we look at those 3 infections plus trichomoniasis, then it's estimated that there were more than 1 million cases per day globally of just those 4 infections. So just to give you a sense of the magnitude of the problem that we're dealing with here. And then zooming in closer to home in the US, the most recent data that we have is were published just this year, but these data are from 2022, so we're a couple of years behind. And there were more than 2.5 million cases of just 3 infections: chlamydia, gonorrhea, and syphilis. And I just want to make the point, it's probably obvious, but I'll make it anyway, that these are the reported cases. So really, we're looking at the very tip of the iceberg. And there's a huge number of asymptomatic infections that won't have been reported to the CDC. And you can see underneath there are some graphs with different trajectories with red arrows, and I'll come back and I'll discuss each of these individually. So thinking about some STIs of public health importance, and in this talk I would need probably 12 hours to try and cover comprehensively all of the different sexually transmitted and sexually associated infections. So of course I'm not going to do that. I'm just going to focus on a few to give you a flavor of what is important, both clinically in terms of public health and thinking about how we may advocate for the populations that we serve. So I'll turn first to chlamydia. In 2022, there were more than 1.6 million cases reported to the CDC. So that's in 1 year. And in 2022, we saw a slight increase in men by about 2%, and in women, a decrease in reported cases of chlamydia of about 1.2%. At the top of the slide here, you can see the age distribution. So these are rates per 100,000 population. And what is very evident here is that the group that is most impacted by chlamydia are those aged less than 25 years. And underneath that, you'll see what I consider a very sobering graphic that is produced by the CDC that looks at the distribution of chlamydia infection by race, ethnicity, and shows the disparities that we know to be evident in STIs across the US, but this just brings it home in a very visual way. This next slide is looking at chlamydia rates in a slightly different way, but telling a similar story. So you can see at the top here that in terms of the rate per 100,000 population, that Black and African American populations are have the highest rates, followed by American Indians and Alaska Native people. And then underneath that is a map of the US, which shows the burden of chlamydia in different states. So the darker the blue, the higher the rate of chlamydia infection. And I'm going to show you a series of these similar graphics for different infections, and most of the themes are the same with some variation, and I'll point those out as we go. The majority of infections with chlamydia in both men and women are asymptomatic. So people will not have symptoms, they don't know they have infection. And up to 15% of untreated chlamydia infection in women will result in pelvic inflammatory disease, or PID. The way that we diagnose chlamydia is really simple, really straightforward. We can use urine, so the first catch urine in people with a penis, and a vaginal swab in people with a vagina. The vaginal swab is underlined and in bold because there have been several studies that have really demonstrated that a vaginal swab is superior to a urine test when we're looking at chlamydia infection in women. So I would always recommend that, if possible, that we provide our patients with the best modality so that we get the most accurate result, and that is definitely vaginal swabs in women. Of course, it's not always possible, appropriate, or acceptable. In those situations, then a urine will suffice. You can also take urethral swabs, throat swabs, and rectal swabs. So the clinical manifestations of chlamydia, they include urethritis and cervicitis, so inflammation in the urethra or inside the penis and in the cervix. We can see infection in the epididymis and the prostate in men, and as I've mentioned, pelvic inflammatory disease in women. Infection in the rectum and in the throat is typically asymptomatic, so people will have no symptoms whatsoever. Chlamydia can also infect the conjunctiva, so the front of the eye, in both adults and in babies born to mothers with untreated chlamydia infection. And chlamydia can also cause this poorly understood but very real autoimmune disease. And you can see the picture on the bottom right. There's a patient with quite a swollen right knee. And this is an individual who previously had chlamydia and that now has an autoimmune manifestation of that previous chlamydia infection. In terms of treatment, the treatment for chlamydia is really straightforward. And you will see this slide several times. It's guiding you to have a look at the STI treatment guidelines that are available from the CDC in the link at the bottom of the slide. They're also available in an app, and I use this every day because my brain works in a certain way, and remembering doses and durations is not one of my strong points. So I rely on this heavily, and it's a really easy guide. So for chlamydia, the treatment is either doxycycline 100 milligrams twice a day for 7 days. That's the preferred treatment. But the alternative treatments include azithromycin at 1 gram as a single dose, or levofloxacin 500 milligrams once daily for 7 days. So for sure, doxycycline is the preferred drug, and in certain parts of the body, like the rectum, for example, chlamydia has been demonstrated to be superior to azithromycin, for example. Let's move now to gonorrhea. And in 2022, there were almost 650,000 cases of gonorrhea reported. And during the 2021 to 22 year, the rate of gonorrhea decreased by 9.2%. Now, the CDC surveillance report encourages us to be not to overinterpret these results. And the reason that I say that is that 2021, 2022 was still when we were in the throes of the COVID-19 pandemic. So people's access to testing, people's access to healthcare facilities was much reduced. So it's likely, although only time will tell, it's likely that these decreases that we're seeing probably reflect a decrease in opportunity for people to be screened for sexually transmitted infections. And again, on this slide, you'll see that the highest rates in both men and women are in those aged less than 25 years. And again, we can see the disparities by race, ethnicity at the bottom of the slide, which is shown again here at the top of this slide. The distribution of gonorrhea across the US is similar to chlamydia when we're looking at the states that have the highest rates of infection. So gonorrhea is caused by a bacteria called Neisseria gonorrhoeae. For people with a penis, and you can see on the top right image, there's a typical gonococcal discharge there. This is usually symptomatic. So this is the exception to the rule of STIs being largely asymptomatic or without symptoms. In women, however, gonorrhea is commonly asymptomatic, or women may experience very non-specific symptoms. So they might think they have cystitis, they might feel that they have period pain, when in fact, what they're experiencing is a consequence of gonorrhea infection. And at the second image in the middle is a picture of a cervix, where you can see this mucopurulent discharge coming out of the cervical os. And again, we can use nucleic acid tests, which are molecular tests. They're really sensitive, really specific. This is the same test that we use to diagnose chlamydia. And we can use the same sample types. And again, a vaginal swab is superior to any other sample type when trying to diagnose urogenital gonorrhea in women. We also have the ability to take a swab for culture so that we can try and grow this organism. And this is particularly important when we worry about drug resistance, which I'll come on to in a while. The clinical manifestations of gonorrhea are very similar to those associated with chlamydia infection. The difference is that, unlike chlamydia, that gonorrhea can disseminate, it can spread through the bloodstream and cause something called disseminated gonococcal infection. And this can be manifest in lesions on the skin. It can be manifest by arthritis when someone has a hot swollen joint. And rarely, thankfully, the organism can lodge on the heart valves, causing endocarditis, and can also spread to the brain, causing a meningitis. And those last two infections are extremely serious and can be rapidly fatal if not recognized and treated. And again, looking at the STI treatment guidelines, for uncomplicated gonorrhea infection, we use ceftriaxone, 150 milligrams as a single dose given intramuscularly. For persons who weigh more than 150 kilos, then we double that to a 1 gram dose. If the person with gonorrhea has had chlamydia excluded, then we don't need to add an anti-chlamydial agent. However, if we're still waiting for that result to come back, if we're unsure, we should go ahead and treat with doxycycline at the dose that I previously mentioned to cover gonorrhea, because often these two infections, they travel together. There are alternative regimens for treating gonorrhea. These include gentamicin, 240 milligrams as a single dose intramuscularly, plus azithromycin. And if you are working in a situation where injectable therapy is not available, then oral cefixime at a dose of 800 milligrams can be given as a single dose for the treatment of gonorrhea. I would add that cefixime is not a good drug for treating gonorrhea in the throat. It doesn't penetrate as well. So that's a caveat for using cefixime when treating gonorrhea infection. So I want to move now and talk a bit more about syphilis, because I think in many ways this is so pertinent for this series, and I hope that will become evident over the next few slides. So in 2022, there were over 207,000 cases of syphilis reported to the CDC. And in a single year, we saw a 16.9% increase in the rate of reported cases of syphilis. So almost 17% increase in a single year. And to me, that's really alarming for reasons that there are many reasons. One is about the effect that this can have on fetal and pregnancy outcomes. So I'll come to that in just a few moments. Here we see that the age and sex distribution is different. If you think back to the chlamydia and gonorrhea, they were the age group most affected were those under the age of 25 years. For syphilis, it's those aged 30 to 34, so a slightly older age group who have the highest rates of syphilis infection. And this slide is showing us the rates of primary and secondary syphilis. So these are the two early stages of syphilis that are most infectious, and that's why we focus on these stages. And again, we see the differences by race, ethnicity in the image at the bottom of the slide. In terms of where the highest rate, so this isn't the highest number of cases, but this is the highest rate per 100,000 population of primary and secondary syphilis. We can see that this is in American Indian and Alaska Native peoples, followed by Black and African American people. And the distribution of primary and secondary syphilis looks slightly different, with more cases towards the west of the US compared with the southeast, as we've seen for both chlamydia and gonorrhea infection. And this is coming to the slide that no matter how often I present these data, it always catches me. And the reason for that is that when we're thinking about congenital syphilis, this is where a fetus or a newborn is affected by syphilis infection. This is completely preventable. So there is no reason why in 2024 we should see any cases of congenital syphilis, but we do. And in 2022, there were 3,755 cases of congenital syphilis in the US. And in a single year between 2021 and 2022, there was a 30%, more than a 30% increase. And my question or my plea, particularly when I'm speaking with policymakers, is how can this be acceptable if we saw a 30% increases in a single year in myocardial infarction, in breast cancer deaths, in stroke? There would be a national outcry and a huge amount of resource would be poured in to try and address that. And sadly, I think sexually transmitted infections are marginalized, stigmatized, and I think that there just isn't proper care and attention and resources given to the prevention of STIs, particularly around syphilis and congenital syphilis. And the reason that we're seeing these increases in congenital syphilis is because we're seeing increases in primary and secondary syphilis among women of reproductive age. So in the chart on the top, in the black line, you can see the increases in rates of syphilis in reproductive age women. And in the blue bars, we see the increases in congenital syphilis. So where rates of syphilis increase in women, then invariably we see an increase in congenital syphilis rates. And again, the population that is most impacted in terms of rate is our American Indian and Alaska Native peoples, followed by Pacific Island populations. So that the American Indian Alaska Native people have really a huge problem with congenital syphilis, and it's a group that we really need to pay special attention to try and address this and try and reduce the rates of congenital syphilis. And again, here we can see the disparities in congenital syphilis diagnosis when we compare on the left live births and on the right the proportion of cases of congenital syphilis. So syphilis is a big talk in and of itself, and I don't have time to anywhere near do it justice, but I would like to draw your attention to this great review that was published by a friend and colleague of mine, Khalil Ghanem, in the New England Journal of Medicine in 2020. And it's got some really nice images, and this one in particular is very useful. It takes us through the different stages of syphilis. So we can see after infection, if we look at the top left, the first stage is primary syphilis, and this is characterized by a lesion or an ulcer. And then a month or two after that, if it's not treated, people will develop or may develop secondary syphilis that is characterized by a whole host of different signs and symptoms, including fever and rash. If syphilis isn't treated, then people go into what we call a latent state, and that means that they have syphilis, but they have no signs, they have no symptoms. The only way that you know they have syphilis is by taking a blood test. So latent syphilis just means somebody has the infection, but they have no demonstrable evidence of infection. The only way we find it is by drawing blood and doing serological tests. And then latency is divided into two. Early latent, when people have had infection for less than a year, and late latent when they've had infection for a year or more. And you will see that's important when I come to talk about treatment of syphilis. So most people, 70% of people who have syphilis and it isn't treated, they will continue their lives without any problem. In a minority, so in about 30% of untreated people, they may go on to develop what we call tertiary syphilis, and this is late manifestations of syphilis. This can affect the heart, it can affect the brain, the eyes, the spinal cord, for example. One thing that can be really challenging for healthcare providers and patients and policymakers is how we interpret the blood tests that we use to diagnose and monitor syphilis. So I want to give you a really brief flavor of how we use different blood tests in the management of syphilis and try and demystify it a little bit. So when we use blood tests to diagnose syphilis, we use two different kinds. We use these, what we call a treponema antibody, and these are shown here in the orange line. These tests are great because they become positive within 2 weeks, usually, of infection. The problem with them is that once you have infection with syphilis, those tests will stay positive for the rest of the person's life. So they're really good for the initial diagnosis of syphilis, but they are of no use for follow-up and looking at response to treatment. And this is where the non-treponemal tests, the RPR test, which most of us use, comes into its own. This test allows us to monitor response to treatment, and it allows us to detect evidence of reinfection. So when we measure the RPR, what we do is we follow it over time and we look for a decrease in the RPR titer over time. And the definition of serological response is that RPR falls by 4-fold or more after the adequate time period has lapsed after the syphilis has been treated. So we use these tests in tandem. You know, they really are, they work best when we use them together, but each of them has limitations, and I just wanted to draw your attention to that. In terms of treatment of syphilis, again, I'll go back to this image that tells us about the different stages of syphilis, and the reason that that's important is because the stage matters in terms of the treatment that we give. So syphilis therapy, for the umbrella term early syphilis, so that's primary with the ulcer, secondary with the rash, etc., and thirdly, early latent, so infection within 1 year. Those stages of syphilis we treat with a single dose of benzathine penicillin, 2.4 million international units intramuscularly. And if someone has a penicillin allergy, if they will not agree to having a benzathine penicillin injection, which is certainly painful for some people, then an alternative is doxycycline at a dose of 100 milligrams twice a day for 14 days. Ceftriaxone can also be used. Azithromycin used to be used, but because of resistance to that class of antibiotics in Treponema pallidum, that's the bacteria that causes syphilis, azithromycin is no longer recommended for treatment. And in pregnancy, we must only use penicillin. And if the pregnant person has allergy to penicillin, then an urgent admission for desensitization and treatment is required. For latent syphilis, so the infection that's been there for a year or more, we use a very similar treatment regimen, but we just give it over an extended time period. So we give the benzathine penicillin at the same dose, but we give it once a week for 3 weeks. And with doxycycline, instead of for 14 days, we used it for 28 days. You can stretch the interval. Ideally, we want people who are receiving bicillin to have, or benzathine penicillin to have the treatments exactly at weekly intervals. It is permissible by CDC guidelines that you can stretch that out to 10 to 14 days in a non-pregnant patient. In pregnancy, we really try hard to keep it to the 7-day interval, although the new guidelines do say that we can stretch out up to 9 days between doses in pregnancy. I want to switch gears a little bit and just sort of try and help to visualize or conceptualize different ways of approaching patients who present with symptoms of STIs. Because patients will sometimes come in and they'll say, I have gonorrhea or I have chlamydia. And occasionally they're right. And in fact, frequently they may be right because they will have had the infection before, they'll have done their own research. But typically, people don't come in to you with a diagnosis, they come in with a set of symptoms or a syndrome. And one really useful approach to STIs is to try and think about the different syndromes that people will present with. So we can think about discharge syndromes. So discharge coming either from the urethra or the cervix that's caused by gonorrhea, chlamydia, Mycoplasma genitalium. We can think about vaginal discharge syndromes caused by trichomoniasis. I put bacterial vaginosis and yeast in parentheses because we don't consider these typical sexually transmitted infections, but they're so common that they're worthy of mention on this slide. And then we have STIs that are associated with genital ulcer disease or sores in the genital area and in other places as well. And we can divide these into painless causes of genital ulcers and painful causes of genital ulcers. I would say that this dichotomy doesn't always work. In fact, frequently it doesn't. But typically the painless causes of genital ulcers are syphilis, and then a condition called lymphogranuloma venereum, which I'll talk about in a moment. And then this very rare condition called granuloma inguinale, which is something that we just really don't see in the United States. Thinking about painful causes of genital ulcer disease, these include herpes simplex type 102, M.P.H, and again, an infection that is very rarely seen in the US, chancroid. And then finally, the third box here in the green is sort of miscellaneous syndromes associated with STIs. So proctitis, infection of the anorectal area, can be caused by gonorrhea, by chlamydia, LGV, herpes simplex, and M.P.H. And just remember, as I've mentioned previously, that chlamydia and gonorrhea can both affect the eye and can cause serious disease there. So proctitis, so this is infection in the anorectal area. As I've mentioned, there are different causes, which I've listed again. And you can see I have two lines here for chlamydia. There's chlamydia D through K, and this is what we think of as the typical urogenital chlamydia. So when people discuss chlamydia, that's what they're talking about, these D through K types of chlamydia. But there's also another subtype of chlamydia that's the L1, L2, and L3 biovars, and this is the strain of chlamydia, if you like, that's associated with LGV or lymphogranuloma venereum. So LGV was, when I was in medical school, which is admittedly a long time ago now, was sort of a curiosity that we learned for medical school and board exams, and it wasn't really something that we dealt with, at least in the UK. It was something that was deemed to be a tropical infection. But what we've known, what we've been made aware of and reminded of over recent decades is that this infection is prevalent in the US. It's seen almost exclusively in men who have sex with men in the United States, and it's associated with infection in the rectum. So it can cause proctitis with diarrhea, rectal bleeding, pain, constipation. If it isn't recognized and treated properly, then it can lead to rectal scarring and stricture formation. And it can be very severe. And I've had several patients over the last 20 years who've been worked up and treated for inflammatory bowel disease. But in fact, the thing that was causing their symptoms all along was LGV. Once that was treated, all of their symptoms went away. And we treat LGV in a similar way that we treat other forms of chlamydia. We use doxycycline, 100 milligrams twice daily. But instead of 7 days, we use a 21-day course in order to treat this LGV infection. So if a patient presents with symptoms of proctitis and you assess them and you think that they may have a sexually acquired proctitis, then the treatment that we offer covers gonorrhea with ceftriaxone, it covers chlamydia and LGV with doxycycline. And if there's a concern for herpes simplex, then please remember to add on an antiherpetic agent such as valacyclovir. And when you get the lab results back, you can modify the treatment and sort of rationalize the treatment. Okay, so what I will do now for a few minutes so that there's enough time for discussion, I want to just present a couple of cases, if I may, unless there are any questions or comments that I should be aware of after that real roller coaster through chlamydia, gonorrhea, and syphilis. I can't see the chat, so
I think you're good, Matthew. Go ahead.
Thank you. So the first case, this is a 20-year-old cisgender woman who attends a primary care clinic for a regular contraception follow-up visit. She reports 4 days of malodorous or offensive smelling vaginal discharge. She has no pelvic pain or bleeding. She does report 2 new male partners in the past 4 weeks. Sometimes she uses condoms, sometimes she doesn't. And on exam, she has a thin, homogeneous discharge in the vagina. The pH is raised, and there's a fishy odor that's discernible from that discharge. On a pelvic exam, she has no evidence of cervicitis and no evidence of pelvic inflammatory disease. So I think it doesn't work so well with an online audience, but what I've presented here is 4 options of things that you might do. So maybe just take a minute to read them and think about which of these options you would undertake. And if anyone feels strongly, you don't have to even feel that strongly. If anyone wants to offer an opinion, please unmute or put in the chat which of these options you would do if you face this scenario. So you can send off nucleic acid tests for chlamydia, gonorrhea, and trichomoniasis, and then you wait until the results come back and treat. You could treat with azithromycin as a single gram and tell her to come back if her symptoms don't resolve. You could treat with ceftriaxone plus doxycycline and tell her, tell her to come back if her symptoms don't resolve. Or you could send off the gnats for chlamydia, gonorrhea, and treat for bacterial vaginosis with metronidazole at a dose of 500 milligrams twice daily for 7 days.
Matthew, I'll help you. There's a lot of voting in the chat for number 4 with a couple for 3.
Okay, great. Thank you so much. I have nothing to teach this audience. Yeah, so there are pros and cons, and it's always context specific, right? It depends on shared decision making with the patient and what their priorities are and what seems like the most likely scenario. But my decision would be to make sure that we have the STI tests sent off so that they can be being processed in the lab, and then treat this woman for bacterial vaginosis. She has textbook bacterial vaginosis, and the treatment for that, as mentioned, is with a 7-day course of twice daily metronidazole at 500 milligrams. So we've talked about vaginal discharge, and just as a reminder, these are the common causes of vaginal discharge syndrome. This woman may have trichomoniasis, and that result will come back when the NATS tests come back for those chlamydia, gonorrhea, or trichomoniasis. We don't know that today, and the symptoms and clinical findings of bacterial vaginosis and trichomoniasis can be very similar. So let's say that her test came back and indeed she had Trichomonas vaginalis. You will have already treated that with the treatment that you've given her for bacterial vaginosis, because the treatment for trichomoniasis is metronidazole, as I've mentioned, 500 milligrams twice a day for 7 days. In men, the recommendation is metronidazole as a 2-gram single dose, and an alternative for either men or women is tinidazole 2 grams as a single dose. I want to now move to my second case, or our second case. This is a 24-year-old man who has sex with other men, who attends his primary care provider for an annual visit. It's sort of in an offhand way, he mentions that he caught his penis in his zipper a few days ago, and he's noticed something there, but he really doesn't think it's anything of any consequence, and he's sure that it's a result of a zipper injury. It's amazing how often I hear that as somebody who has spent many years providing care for people with STIs. There's a desire amongst many people to discount the possibility of an STI and try and minimize some of the symptoms that go with it. So this is rhetorical, of course, but what else would you want to know? So some of the things that are key are the sexual history. When was he last sexually active? His number of sex partners in the previous 3 months, how often he uses condoms, does he use condoms for oral sex, anal sex, both, neither? Is the lesion, the zipper lesion, painless or painful? And has he had previous episodes similar to this? And the reason to ask this question is if somebody says, I had the same problem in exactly the same place 4 times in the last year, then it really makes you think that this may very well be herpes simplex. You also want to know about travel. Could he have been to a place where he's been exposed to some of those uncommon infections that I mentioned, such as chancroid? And what is his vaccination and medication history? And this seems a little bit left field, but the reason that I mentioned medications is that there's a phenomenon called a fixed drug eruption that will often present on the genitals that can look like a sexually transmitted infection. So when you do conduct an examination, this is what you see. So these are 4 different slides representing different pathogens here. And remember that when we're thinking about genital ulcers, these are the organisms that we're thinking about. So just to orientate you on this slide, so from left across the top row, first one that we see is a primary syphilis lesion, textbook, clean base, solitary, painless lesion. Next to that is this crop of vesicles that's classic of herpes simplex. And then next to that is some skin lesions that are actually M.P.H that could be many other things, but actually that's what we're looking at here. And then the image underneath is infection with chancroid. As I mentioned, this is something that many of us will never see in our careers. So moving on from some of the cases, I want to just spend a minute or two thinking about screening for STIs. And before I do that, I'll just reinforce the point that the majority of STIs are asymptomatic. And there are ways that we can help our patients with screening. There are available online resources such as I Want the Kit, which is on the top right here. This is a free internet resource for patients in several states now across the US, where they can access free online STI kits that's mailed to them at home. They collect the samples, mail them back, and have their results via a secure portal. So this can really help patients to feel in control of their sexual health and well-being. And when we're providing testing in clinical sites, the majority of the time, patients can collect their own swabs. So what I'm showing on the bottom left are some visual guides that are available from the University of Washington that you can put up in the restroom or in the clinic room that show people how to self-collect vaginal, rectal, pharyngeal swabs, and these are available in different languages. I've tried to summarize the CDC screening guidelines here. It's pretty busy. I'm very happy to share these slides, but really what it demonstrates is along the left, there are different groups of people. So women, men who have sex with women, men who have sex with men, etc. And then across the top first row, we see the different infections that can be screened for. And in each of the boxes, it will give you some guidance on if we should be screening for those infections within that particular group and how frequently we should be doing it. So the counterpoint to what to screen for is what not to screen for. And if I become animated just now, it's because I feel very strongly about this. So the CDC make it really clear that we should not be screening for Mycoplasma genitalium at this juncture. If someone has persistent symptoms, so persistent demonstrable urethritis or cervicitis, sure, go ahead and order a Mycoplasma genitalium test. It can also be considered in people with Ph.D. The other thing that I would just caution the clinicians and laboratorians and others on this call is that all Mycoplasma genitalium test requests are not made equal. So just be careful when you tick that box that you're only requesting Mycoplasma genitalium. Some commercial labs, they run something called a genital mycoplasma screen, which is a nightmare because it gives you these results for these organisms that we have no idea what to do with, such as Mycoplasma hominis or ureaplasma species. So just before you check that box, think, number one, should I be checking the box at all? Number two, am I checking a box just for Mycoplasma genitalium? And then the other thing that I typically caution about is screening for herpes simplex using serological tests. This can be useful for sure, but in my experience, in very limited situations. And the reason is that screening for herpes using blood tests has really not been shown to be beneficial to patients. I will finish with a couple of slides on prevention of STIs. We know about condoms, we know about vaccine preventable STIs such as HPV, M.P.H, hepatitis B. We know about HIV, PrEP, and PEP. And more recently, in the last 6 years or so, so maybe not that recently, but in the last couple of years, it's really gained prominence, is the idea of prevention of bacterial STIs using doxycycline post-exposure prophylaxis. And again, this is a busy slide that I'm not expecting anyone to absorb, and you're very welcome to access it as you wish and just absorb it in your own time. But these are some of the key studies looking at doxycycline post-exposure prophylaxis. So the take home is that if you give 200 milligrams of doxycycline within ideally 24, but up to 72 hours after condomless sex, so that's anal, vaginal, oral sex, then we can expect a reduction in STIs by about 65 to 70%. Now, data exist for efficacy for doxycycline PEP in two populations, men who have sex with men and transgender women. Currently, there are not data to support the use of doxy-PEP in cisgender women. There was a trial in Kenya, which is on the bottom of this slide here, which did not show a protective effect of doxy-PEP in cisgender women who are already taking HIV PrEP. And to the best of my knowledge, we have zero data on the efficacy of doxycycline PEP in men who have sex with women. So there's some references there, which just, for those of you who are interested in exploring more, can read more about doxycycline PEP. I think it's a really exciting development. So I'll summarize on this slide. The global burden of non-HIV STIs is huge. Rates in the US are continuing to increase. I think we have to watch this space for chlamydia and gonorrhea. Offering testing, patient self-collection, online platforms, and normalizing sexual health discussions can really decrease barriers for our patients. And finally, that doxycycline PEP is an exciting tool in our armamentarium in the protection of people against bacterial STIs. So some resources here, and I'll end with my email. And thank you so much for your time and attention. And I think hopefully we have enough time for some questions.
Definitely do. Thank you so much, Matthew. Great pictures, but also more importantly, great data, including what's been happening with the rates of everything. I think, as you mentioned, the syphilis rates in particular. I know you mentioned the 30%. Marina, I wonder if we can just take the share off, and so we can, both Matt and I and everybody can be visible if they want to be. Perfect. The 30% for congenital, but it was 900% over the past 5 years for congenital, which is insane. So agree with you, opportunity to say, well, why aren't we treating this more as a huge emergency, right? So appreciate that. I wonder, and people can unmute if they have questions or comments for Matthew. He's fabulous. I wondered if you could talk a little bit about the syphilis testing. Constantly drives me bananas. When, how, if, could we get to point of care testing for syphilis in a meaningful way? I wonder if you can talk a little bit about that.
Yeah, I can feel the hairs on my arm standing up when you ask me a question about point of care testing for syphilis, because I think about it a lot. You're not alone. Syphilis testing drives everyone bananas, right? It's really challenging, and I've been advising people on syphilis serology every day practically for the last 2 decades, and still, I have to stop, think, read about it all the time. So in terms of point of care testing for syphilis, we have a point of care test, the rapid RPR, so the RPR test that you can do, costs about $8, takes about 20 minutes to run. you do need the lab setup. So it's not, that accessible. But in terms of newer testing for syphilis, there are a couple of tests that are approved in the US. The one that I've had the most experience of is the one by a company called ChemBio. They produce a syphilis-only antibody test, but also they produce a combined HIV and syphilis antibody test, which is really useful. Take a finger stick of blood. It's very easy to run. You put a little reader on top of the cartridge, and then the reader tells you the result for both HIV and syphilis. And that results in about 20 minutes. So that can be really useful in clinic settings, in outreach settings, in the ED, for example. The problem with it is that remember that there's the treponema test that once positive stays positive lifelong. That's what we're measuring here. So if someone's had syphilis before, it doesn't help you.
Yeah.
However, there is a new test that is available in Europe and I hope will be available in the US, which provides both a treponema and a non-treponema read. So it will be much more useful in people with a past history of syphilis. And I think watch this space until that starts to roll out.
Yeah. Keep watching the spaces. I'm watching
Yeah, I do a lot of space watching.
You to watch the spaces.
Yes.
There's a question about doxycycline from Marshall Takiris about does it matter if it's hyclate or monohydrate in terms of treatment? Question.
Yeah, that's a great question. And I think my answer is no, it doesn't matter either for treatment or for prophylaxis. There's a cost difference, and I can never remember which direction it is in between. The cost can be quite different. So that's the thing that I tend to just to check in with my patients before prescribing it to make sure that they're having a preparation that doesn't have big co-pays, for example, particularly if they're paying out of pocket. But the short answer is it doesn't matter.
Yeah. The other question, I'll just keep talking because we could talk about this literally all day. I had two questions. One, maybe I'll ask them separately. One, I'm always struck by the disparities that we see, and I wonder if you could talk a little bit about why you think we're seeing what we're seeing, and then what do we do about it, depending on what you think the reasons are.
Yeah, I think there's some benefits to being an outsider or being a foreigner, which I kind of still feel that I am, even though I've lived in the US for several years now. I think it kind of allows a bit of a different perspective. And this is, my opinion for what it's worth, but I think, all of the things that we know to be true in the US and particularly in US healthcare, that the structures that really prevent people from accessing care and the structures that put barriers, both intentionally and non-intentionally, in the way of people of color in particular, but also for sexual and gender minority people. And I think that it's everywhere, right? From where the clinics are based, what the opening hours are, whether there's transportation that's available. For I Want the Kit that I mentioned, this online service that I work with that group, I did a quick search to see where the mailboxes are in Baltimore, and you find that you have food deserts, you have healthcare deserts, you have mailbox deserts.
You have mailbox deserts, correct?
It kind of sort of everywhere you turn, I think these disparities exist, and the solution for it, I mean, I don't know. I mean, I think that we have to keep trying to talk about it in the way that we're doing right now, to raise it in people's consciousness, to be aware of our own biases that we may or may not be aware of, and try and be thoughtful and address them, and just shout it from the rooftops. I think it's a disgrace.
Yeah.
It really is, and it's heartbreaking. That's how I feel about it on an emotional level when I'm trying to help someone who has had to overcome all these barriers just to sit in front of me in a clinic room.
Yeah, no, I agree. I mean, as you're saying that, not that I'm a big proponent, except my bills say differently. I mean, there are no Amazon deserts, right? And I wonder if there are creative ways that we could, get the kit through some of these other modalities, right?
Oh, and the Europeans have streets ahead of us in, there are, and this is for economic reasons, because it's much cheaper to provide a service where you don't need a brick and mortar clinic. But there are, across the UK, for example, which I know the best, you can go online, you can order your tests, including blood tests using a microtainer for HIV, syphilis, Hep B and C. And you can order things online. Your tests get resulted, and then they mail you doxycycline. Or if you need emergency contraception and there's enough time, they'll mail it to you. So it's will, money, and resources.
Yeah, you can say that louder, I think, again and again. I wonder if you could maybe talk a little bit about, let me preface by saying we've seen PrEP become available 2012, and we still see horrible uptake for PrEP, right? The PrEP to need ratio is ridiculous. I wonder if you could talk a little bit about doxy-PEP. I understand we have some concerns about resistance or things that could happen, but I wonder, this is one of the first times where we've seen a prophylactic, a preventative sort of, modality, and I wonder what you think is needed to optimize that, and what, how that may impact what we're seeing in terms of rates.
Yeah. So I think the caveat around we need more data in order to determine that this is safe long term. My hunch is that it is, and the cost benefit of 60% reduction in bacterial STIs versus a relatively small risk probably of resistance in Staph aureus, for example, is the trade-off is probably worth it. And I think it's a great segue into HIV PrEP as well. So some people are coming forward and they've said, I don't want HIV PrEP. Get off my case. It's all you talk to me about. All you see is a young black MSM and it's PrEP, 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 PrEP. I don't want it. But people will come forward and self-advocate for doxy-PEP. And I think it can be a great way of just showing how beneficial prophylaxis can be. My experience is relatively limited. We set up a program at the Baltimore City Health Department, and what's clear is, as with so many things, the first wave are well-educated, white, middle-aged men who have sex with men, so people who look like me. And I'm not criticizing those individuals, but there is a problem about equity in terms of access to information, and I think we've got a lot of work to do about that. And how we do it, I'm not sure. I think these things have to be ground up from the community, where people like you and I are providing people in different communities with information so that it can be disseminated, and hopefully then it sort of percolates into the conversations with healthcare providers.
Yeah. Awesome. And definitely doesn't just have to be prescribed by infectious diseases doctors, right? And I think that's the other piece that we need to make sure it's clear.
Yeah, it's really easy. So all of you who have your hands on a prescription pad or on an EMR, honestly, it's so satisfying. It's like popping a big pimple. It's easy to do, and it's gratifying for your patients, and it feels good for you as a provider. So if you have questions about it, please feel free to reach out to me, and I can talk about it until the cows come home.
Well, we will share your slides, and we'll also share the recording. Thank you so much, Dr. Hamill. It was really a pleasure. I can listen to your accent all day. To let everybody know. Marshall is saying the doxy monohydrate is a little more expensive. Thank you for finding that. Our next toolkit on April 18th will be Dr. David Griffith talking about HIV in the rural communities in Maryland and beyond. Again, our pleasure. Thank you for having us, sharing space with us today, and good luck to everybody for the rest of the week, and enjoy. Thanks again, Dr. Mann.
Bye-bye.
Take care.